Hello, my name is Cezmi Akdis. I am the director of the Swiss Institute of Allergy and Asthma Research located in Davos, Switzerland. I'm going to talk about broken barriers based on the concept of epithelial barrier hypothesis. There are major threats to humanity and planet Earth that we have been discussing. I'm going to talk about the health crisis, exposure to toxic substances, and 2 billion patients. And this is based on the epithelial barrier hypothesis. And there is pandemic of infectious diseases that we are experiencing now, COVID-19, and there is Ebola, Staph aureus, antibiotic resistance. Biodiversity loss in the nature and extinction of species is an important threat. And the most important one is ignorance of all of the above problems, anti-vaccine groups, anti-science groups, and also the ignorant global leaders that cause all of these. What happened after 1960s to cause the global health? We are being faced to epithelial barrier damaging substances, and the pandemic of allergy and asthma and other chronic non-communicable diseases started in 1960s. There was almost no Ig and IgG response to allergens in 1970s and 80s, and this developed the ignorance hypothesis. Allergen-specific Ig and IgG response started to increase after that, and in 2015, the Ig reached to approximately 40% of the population and 90% of the allergic patients, and IgG is positive in almost all of the babies at the age of 1 year against milk and egg. And we are also seeing the Staph aureus pandemic. Staph aureus carriers were 4% in 1985, but currently we have 80% carriers, and we have 20% continuous carriers and 30% intermittent carriers. When John Bostock started to mention allergic diseases for the first time, and Charles Blakely collected the first series, there was very few cases. In 1900, the Swiss Army had only 1% of allergic individuals, and in 1960, allergy pandemic started, and there was an increase. We are seeing 8%, 26%, 43%, and this increase in 1960s is associated with surfactants and enzymes, addition in detergents, and in 2000, another epidemic, food allergy, eosinophilic esophagitis, drug hypersensitivity. This is together with dishwasher detergents and emulsifiers that are introduced to our lives. We have these substances that are introduced to our lives with modernization, urbanization, and industrialization. We have laundry and dishwasher detergents, surfactants, ozone, diesel exhaust, nanoparticles, enzymes and emulsifiers in processed food, shampoos and body cleaners, household cleaners, particulate matter, microplastic, toothpaste, gluten sensitivity. And there are also other factors that we have been exposed: cigarette smoke, bacteria, allergens, fungi, viruses, mites. And the effect between these substances is synergistic. And when they are together exposed, much lower doses are efficient. So the epithelial barrier is leaky, and the bacteria is between the epithelial barriers, and they pass below the barriers. This hypothesis started to develop in our minds during the last 20 years. And in the beginning, in our group, we were dealing with epithelial cell death and apoptosis in skin, lungs, and sinuses, which was disrupting epithelial barriers. And major functions of epithelial barriers were described as keep away factors, wash away factors, and suppress factors in 2006. And the immune system and inflammation that regulates tight junction barriers. And we identified detergents, surfactants, ozone, emulsifiers, particulate matter in disrupting the epithelial barriers. So this paper appeared about 5 months ago, and which is highly appreciated. And the talk is based on this paper, and it explains 2 billion patients with allergic, autoimmune, and neurodegenerative diseases. Epithelial barrier hypothesis shows epidemiological links to exposure to toxic substances. It accepts the hygiene and biodiversity hypothesis, demonstrates ways of prevention, suggests future research direction, and needs a huge work for public awareness and education. And here are the diseases. We have 3 groups of diseases. The first one is microbial dysbiosis, and epithelial barrier defect is taking place in directly affected tissues. Atopic dermatitis, asthma, chronic rhinosinusitis, allergic rhinitis, eosinophilic esophagitis, inflammatory bowel, and celiac are in this group. The second group is autoimmune and metabolic diseases that are linked to gut barrier defect, sometimes lung barrier defect, and microbial dysbiosis. And the disease are in distant organs. It is not at the place of the defect. We have here diabetes, obesity, fatty liver disease, autoimmune hepatitis, liver cirrhosis, rheumatoid arthritis, multiple sclerosis, systemic lupus, and ankylosing spondylitis. In all of them, we see a barrier defect, and at the same time, microbial dysbiosis and bacterial translocation in the gut or in the lung. And we have a third group, which is chronic neuropsychiatric conditions linked to gut barrier defect, but the evidence in this group is not as strong as diabetes or obesity or multiple sclerosis, but we have to work on this. In all these diseases, we see some enteric inflammation, barrier defect, and microbial dysbiosis, but there are no models and no direct proof of the epithelial barrier leakiness. Now let's discuss what is going on. What is the mechanism of epithelial barrier leakiness? And we have a homeostatic interaction of epithelial cells and surface tissues with commensal bacteria. It's a live together, co-evolve, select, and support kind of response. The group of commensals are selected to live together with our epithelial cells, and there's an evolutionary selection. And each of the cells and microbes and epithelial cells are supporting each other with nutritional factors, with vitamins, and that's an interesting and very healthy response. What's happening is that when epithelial barriers are leaky, epithelial cells are not touching each other, and microbiome migrates deeper inside the epithelium and gets in contact with basal epithelial cells and stimulates the immune system. And here we have a translocation of the microbiome, which is going into deeper tissues and which is affecting the immune system and gets the immune system activated. What happens is that we have microbial translocation, microabscesses in the colon, sometimes in the sinus that we are seeing this, and a type 2 expulsion response starts. So the immune system tries to get rid of these bacteria that are going deeper in the tissues. And there is at the same time colonization of opportunistic pathogens, Staphylococcus, Moraxella, Haemophilus, Pneumococcus, and also an explanation for the loss of biodiversity because of colonizing opportunistic pathogens and because of immune response to other commensals. So we have antibodies now to our own bacteria, and we are trying to reject them, trying to get rid of them in the tissues. Here is the summary slide. There's exposure to barrier damaging agents and opening of the epithelial barrier, colonization of the opportunistic pathogens, translocation of microbiota to subepithelial areas, immune response to commensals and opportunistic pathogens is taking place, loss of commensals, microbial dysbiosis and decreased biodiversity is happening, and inflammation in the epithelium and chronicity is taking place. Afterwards, there's a defective epithelial barrier, and the healing capacity of the epithelium is defective, and it leads to chronicity and development of 2 billion patients. I would like to take your attention to European academic guidelines on environmental science that we initiated, and there's also a work group on epithelial cells. I would like to thank all of you for listening and wish you a successful meeting. Thank you.